Thank you for joining us for this MDA community webinar. My name is Nicole Petrowski, and I am the Program Specialist in the Program Development Department. We are thrilled to have you join us today for this important and educational on-demand webinar. The webinar today is part of our larger MDA Engage flagship community event series, which focuses on bringing the neuromuscular community together around education and social opportunities. Be sure to visit the MDA Engage section on mda.org for updates on upcoming in-person and virtual education events. Before we begin, I would like to say thank you to our speakers, whom you will meet shortly. Also, thank you to our event supporter, AveXis. We wouldn't be able to provide events like this if not for their generous support. So thank you very much. Muscular Dystrophy Association is committed to transforming the lives of people affected by muscular dystrophy, ALS, and related neuromuscular disease. We do this through innovations in care and innovations in science. MDA's research is vast that we do. MDA is the largest non-governmental funder of neuromuscular research in the country. To share a little bit specifically about MDA's work in the SMA research landscape, MDA spent more than $500,000 on SMA grants in 2019. Total number of SMA grants active at any time in 2019 is 14. MDA has spent nearly $4 million on SMA grants in the last 5 years. And since its inception, MDA has invested more than $48 million in SMA research. With that foundation, let's review the objectives for today's webinar. Participants will review what gene replacement therapy is and how it works, discuss the approved gene replacement therapy for SMA, Zolgensma, how to get involved with your local care center, and learn how to navigate that clinical experience. Also, you will learn how to start therapy and manage your out-of-pocket costs and learn about the One Gene program. Now I would like to introduce you to our two speakers. Dr. Crystal Proud is the director of the Neuromuscular Clinic and Spinal Muscular Atrophy Center at Children's Hospital of the King's Daughters, working collaboratively to provide a comprehensive approach to patients with neuromuscular diseases. She attended college at the University of Virginia, where she majored in neuroscience, and then studied at Eastern Virginia Medical School, where she received her doctorate of medicine. She pursued general pediatrics training in Atlanta, Georgia at Emory University. She then trained in neurology to receive special qualifications in child neurology at Stanford University. She remained at Stanford for her neuromuscular medicine fellowship and then returned home to Virginia to join her current practice as part of Children's Specialty Group, serving the patients at Children's Hospital of the King's Daughters in Norfolk, Virginia. During her subspecialty training at Stanford University, she participated in landmark clinical trials, including one that supported FDA approval of the first treatment for spinal muscular atrophy. She has continued this interest at CHKD, where she now serves as primary investigator for several clinical trials, evaluating novel treatments for patients with various neuromuscular conditions. Her research focus is the development and conduct of therapeutic trials for spinal muscular atrophy and Duchenne muscular dystrophy. Dr. Proud serves as a medical director for the CHKD Novel Therapeutics and Gene Therapy Center, with a commitment to optimizing clinical care and offering participation in clinical research to patients and families with rare disease. Tanicia Johnson is a specialty program coordinator at Children's Hospital of the King's Daughters in Norfolk. She graduated from Practical Nursing School in November of 2017. After passing the boards, she began her journey at the Children's Hospital of the King's Daughter in the Child and Adolescent Neurology Office. She has been working with Dr. Proud ever since. And with that, I would like to turn this webinar over to Dr. Crystal Proud.
Thank you so much for having me here today. It's a pleasure to be able to discuss gene replacement therapy for the treatment of SMA. I've outlined some objectives today, including reviewing the diagnosis of spinal muscular atrophy, discussing the mechanism of gene replacement therapy, providing an overview of gene replacement therapy as it pertains to SMA, outlining gene replacement therapy administration procedures, and then revisiting the model for multidisciplinary care. So we'll start with the diagnosis of spinal muscular atrophy. And most of us in medicine prefer to discuss a diagnosis as it relates to patient cases. And so I'd like to share with you a few cases that are examples of types of patients that I care for in my own clinic. The first is an 11-year-old young man who came to see me in my neuromuscular clinic for consultation because he had had more tripping and falling recently that his mom had noticed. He enjoyed basketball, but he was certainly slower than his peers. He could jump a little bit, but certainly not as well as his friends. And he had difficulty going up and down stairs, requiring taking one step at a time. His mom recalls that he really walked a little bit differently as early as 3 or 4 years old, and she would notice that he would be up on his toes intermittently as well. He also is noted to have a tremor in his hands, and it's not been bothersome to him, but it's been persistent. Our second patient case is a 17-month-old little boy who came to see me because his mom was worried that he had started to lose milestones that he had previously gained. And as a neuromuscular physician, that is a significant red flag if you lose muscle strength that you once had. When placed along the furniture, he would take a couple of steps to cruise around, but he could not accomplish getting up on all fours to crawl any longer, whereas at one point he could. He continued to sit independently, and he was, like I had mentioned before, able to cruise, but not able to pull into that standing position any longer. The third patient is a 4-month-old little girl, and she's the more typical story that I think most pediatricians have in mind. She actually went to go see the pediatrician for her well child check, and her pediatrician reached out to me because she noticed that the baby was having difficulties or differences in the way that her chest and abdomen were moving when she was breathing. She had poor head control, and her parents noticed that her cry was quite soft. She was not reaching out for toys, mostly because it seemed that her arms wouldn't allow her to do so, and she was not kicking into the air. These are all 3 examples of patients diagnosed with spinal muscular atrophy. And here we'll talk a little bit about what we call the phenotypes. So in medicine, a phenotype is what we describe as kind of the characteristics of a person with a certain diagnosis. And so in the past, we commonly referred to patients with spinal muscular atrophy as having types 1, 2, and 3 most commonly. And these were purely attributed to a patient based on how strong they were. And so if you achieved the ability to sit, you were considered a type 2. And if you had not achieved that ability, you were a type 1. If you had achieved the ability to walk, you were considered a type 3, even if at some point you lost that ability. And we utilize these typings for a couple of different reasons. We use these typings in order to provide a prognosis to families. So we know that our type 1 babies typically did not survive beyond 2 years of life. In our type 2 and type 3 patients, we would be able to discuss some of the interventions that might be necessary from a supportive perspective as they went throughout their life. It's important to know that the genetic mechanism for each of these types of categories is actually the same. And it can be a bit confusing because one can think, well, I have this many copies of the backup gene SMN2, and if I have 2 copies, I'm a type 2, or if I have 3 copies, I'm a type 3. But that is not actually the case. The attribution is purely assigned based on these strength characteristics. In an era of current treatment, these categories are becoming less relevant, and many of us no longer utilize these to characterize our patients and refer to them purely in a historical sense, but they are worth mentioning here. So let's talk a little bit about the genetics of spinal muscular atrophy and why each of these phenotypes is characterized by a similar change in DNA. And to do that, we'll start out by talking about the anatomy. The motor neuron projects to the muscle, and it's important to know where that motor neuron is located. It's sitting in the frontal portion of the spinal cord. So the cell body of the motor neuron sits in the front of the spinal cord and then reaches its projections out toward the muscle. And so when the body desires to make a movement, that signal is sent from that motor neuron out through the projection of the nerve to the muscle, and then the muscle can perform a movement. This whole complex is supported by the survival motor neuron protein. And so the next thing we'll talk about is how that protein is produced. Protein throughout the body is produced by our DNA. And so there are two genes worth discussing in this context. The first is called the survival motor neuron 1 gene, and the second is the survival motor neuron 2 gene, and they serve different purposes. The survival motor neuron 1 gene is primarily responsible for producing that survival motor neuron protein that's necessary to keep those motor nerves healthy and intact. But we all have a backup gene called the SMN2 gene. That SMN2 gene is a faulty gene, and it produces functional protein, unfortunately, only about 90% of the time. And that is because of a phenomenon called alternative splicing, which I won't go into too much detail about here. In most individuals who do not have a diagnosis of SMA, they rely fully on that SMN1 gene to produce the protein that they need. But patients with SMA have a missing or mutated SMN1 gene, and so they are only relying on that backup SMN2 gene. And remember that that is a faulty gene, and so they only are receiving about 10% functional protein from that SMN2 gene. And as a result, that is not sufficient to maintain motor neuron health. And over the lifetime of that patient with spinal muscular atrophy, that motor neuron is going to deteriorate. Patients with SMA have progressive muscle weakness related to this unhealthy motor neuron and the deterioration that it suffers throughout the lifetime. And so that leads to progressive weakness of muscles that are throughout the body. And it's easy to think about the muscles of the arms and legs because those are the ones that we think about when we think about strength, but we can't forget those muscles around the rib cage and the diaphragm muscle as well. And so we do see that our patients with spinal muscular atrophy have respiratory impacts of their diagnosis as well. Diagnostic testing for SMA can be performed from two types of samples. A blood test is the most common way that we would diagnose spinal muscular atrophy. There are some testing kits that permit a saliva sample to be collected in order for the DNA to be examined. And so if a test for SMA is being sent off, the results will return to us commenting on whether or not there is a missing or mutated SMN1 gene. So healthy individuals that do not have spinal muscular atrophy will have 2 copies of that SMN1 gene. A carrier will have 1 copy of that SMN1 gene, and an affected person will have no copies of that SMN1 gene, most likely. The report will also share with us the number of backup genes, so that SMN2 gene copy number. And once again, especially in the case of a baby where you may not have had so much development to assess thus far, it can be easy to look at that report and say, well, I have a child that has 2 copies of that SMN2 gene, and that must mean they're going to be a type 2. But remember, this is not a one-to-one correlation with the number of SMN2 backup gene copies. So we're going to transition now to talk a little bit about gene transfer therapy. And I'd like to start by talking about this in a more broad sense, because we know that we are currently in an era where we have many novel therapeutics coming down the pipeline that have pursued this type of treatment modality. So Let's start with the capsid. The capsid serves as a delivery mechanism. So this is actually the shell of a virus. So in the setting of gene delivery, what the manufacturers have done is taken out that viral material. So they've removed that viral material from the inside of the capsid, and all that is left is a shell. And then we can place into that shell what we would like to deliver. And so in this case, that is going to be a piece of DNA. So you see that the DNA is now inside of this capsid. That capsid can be administered to the body, and then ultimately it releases its contents. And so the DNA is now inside of a patient's body. And DNA, as we have mentioned before, has a role of creating protein. And so that DNA will hopefully continue to make the protein that it was designed to make. There are potential adverse effects when we're talking about gene transfer therapy. So this is a vector delivery system whereby that capsid is going throughout the body potentially. So if this is an intravenous administration, the body has ways of filtering materials that are going throughout the bloodstream. And so it may, as it is traveling throughout the body, lead to inflammation of various tissues and organs. And the ones that we most commonly think about and pay close attention to are the liver and the heart. So we've talked a little bit about gene transfer therapy as it relates to a more broad sense of how we're delivering a piece of DNA to the body. But now let's focus more closely on delivering a piece of DNA in the setting of spinal muscular atrophy. So onasemnogene abeparvovec, more commonly known of as Zolgensma, was FDA approved on May 24th of 2019. It is indicated for the treatment of spinal muscular atrophy in children who are less than 2 years old. And because of its mechanism of action, whereby it delivers that missing SMN gene, the treatment potential is completely independent of phenotype. And this is a really critical thing that we pay attention to, that this is going to apply to a patient with spinal muscular atrophy, no matter whether they are type 1, 2, 3, or any other phenotype that we've labeled them as having, simply because the underlying mechanism of having spinal muscular atrophy is a missing or mutated SMN1 gene, and here we are serving to replace that gene. In clinical trials, AAV9 antibody titers were less than or equal to 1 to 50 prior to infusion. And if titers are elevated, retesting can be performed. This testing is available commercially through a blood test, and on many occasions, the diagnostic testing for spinal muscular atrophy can be performed at the same time as testing for these AAV9 antibodies. Significantly elevated antibodies may impact potential efficacy of the medication. It is not necessarily related to adverse effect, and that's a common misperception. If my child's antibodies are elevated, does that mean that I'm at risk of having more adverse effects from the medicine, more intolerability from the medicine? But in fact, because we're dealing with the administration of a viral vector, that capsid, we do not want the body to react against that capsid and allow that medication to essentially be inactivated and not serve its purpose. Potential adverse effects as they relate to onasemnogene abeparvovec include elevated liver enzymes. This goes back to what we were talking about with regard to the potential for liver inflammation when we're administering this type of product. Vomiting was seen in about 6.8% of patients, and low platelet number was seen in about 5.5% of patients. In the patients that I have treated at my institution, that low platelet number tends to happen early on, perhaps within the first or second laboratory value that we obtain, and then returns back to typical values thereafter. And the elevation of liver enzymes can happen at any point within the laboratory testing that we'll talk about in a moment. Many institutions have noticed that patients have reported fever. And so while this is not in the product insert, I felt it appropriate to share this potential for adverse effect with you in order to make you more aware. So let's talk a little bit more about delivering Zolgensma. So once again, we have this capsid, this shell of a virus. And this particular virus that was chosen, this shell, is the AAV9 capsid. So that's the adeno-associated viral vector type 9. Remember, that is non-infectious. So this is purely the shell of the virus. And in the wild, adeno-associated virus type 9 is not actually infectious in human anyways. And so you may say, well, if it's not infectious in humans, why then might we have antibodies to it? Why do we have to do that blood work if it's not something that can infect us? It is such that the body can be exposed to AAV9 just in the environment, and that is considered something called an antigenic interaction, whereby the body, even though it is not an infectious interaction, will create an antibody against that AAV9. And so this is the rationale for checking AAV9 antibody titers in our patients who are considering therapy. So we have this adeno-associated virus type 9 capsid or shell, and inside of it has been placed the SMN transgene. This is a single-stranded piece of DNA. Remember that most of our DNA, or all of our DNA, is double-stranded. So this is a single-stranded piece of DNA that has been placed inside of this shell, and it is administered intravenously. It is administered in a volume and a strength that is based on the patient's weight. Once that product is administered intravenously, it circulates in the bloodstream and then crosses what's called the blood-brain barrier. This is the barrier that typically protects the brain and the spine and its contents from the blood. And so it is not easy to cross this barrier. This is a delivery system that has been specifically constructed to allow this product to cross the blood-brain barrier. It targets those motor nerve cells that, remember, are sitting in the frontal portion of that spinal cord. You can see that the next step is whereby the capsid, or that viral shell, releases that piece of DNA into the motor neuron cell nucleus. At this point, it wraps up into a circle that we actually call an episome. It is double-stranded and then begins to produce the survival motor neuron protein. That protein is a totally new protein that is made from the completely new gene that we have delivered to the patient's body. So administration of gene transfer therapy, I wanted to share our hospital's experience. So we have dosed 8 patients now with Zolgensma, and when we first began looking at how we were going to administer this therapy, we looked to our experience from being a clinical trial site and the protocols that we had established for the clinical trials, and examined how we could modify these to clinical experience after the FDA approval. We identified 2 locations within our hospital where this medication could be administered. And so the first was our outpatient infusion center. As many large hospitals have, we have an infusion center that is on the first floor of our hospital and is considered outpatient. So the patient can check in, have IVs placed, and then be discharged within the same day. We also are fortunate to have a neuroscience unit that specializes in taking care of patients with neurological conditions. And so the other option that we identified was the potential to have our patients arrive to the neuroscience unit, which is technically within the inpatient side of the hospital, but we could continue to have our patients stay overnight, just one night if we needed to, for what's called an observational stay. And when we're talking insurance, that observational stay is typically billed as an outpatient billing scenario. It's important to keep in mind that because of all of the things that we have talked about, in particular with regard to the complex needs of the spinal muscular atrophy patient and the potential for severe adverse effect, administration of this medicine should occur in a center that can continue to provide comprehensive neuromuscular care under the direction of a neuromuscular expert, and this is traditionally a neuromuscular neurologist or a physiatrist in the treatment of patients that have spinal muscular atrophy. So gene transfer therapy administration, I figured that I would break it down into different days. So at some point prior to infusion, we need to get baseline labs. We need to make sure that we have evaluated the platelets, the liver functions, and those liver functions can include measures such as AST, ALT, total and direct bilirubin, and PT. And then looking at heart function through a measure called troponin I. These are all blood tests. On the day prior to infusion, we administer what's called a corticosteroid. And so this is a prescription medicine. It can come in liquid or pill formulation, but for most of our younger children, we use the liquid. It can be picked up at a typical pharmacy, and the doctor can call in this medication. We usually use prednisolone, and we dose this based on weight, 1 milligram per kilogram per day. It's traditionally given once daily, and I usually recommend that my patients take it in the morning because if you take it in the afternoon or evening, it may interfere with sleep because some people can feel a little bit energized. We consider prescribing a GI protective medicine while our patients are taking prednisolone, and usually this may come in the form of either ranitidine or famotidine, and that's just because sometimes this corticosteroid can irritate the tummy. On the day of the infusion, the patient will show up, and we will continue to administer that prednisolone oral daily dose, so we do not skip a dose of that medication on the day of infusion. We place 2 IV lines, and as is commonly known, many of our patients with spinal muscular atrophy can have difficult venous access. And so at my hospital, we notify the vascular access team, and they are prepared to come to our patient's bedside in order to place these IV lines, and if necessary, they can use techniques like ultrasound or other assistive devices to be able to place these IV lines. We place 2 IV lines because if we start the infusion of the medicine and for some reason the IV becomes faulty or stops working, we want to waste no time in switching over to the other point of access and continuing administration of the medicine. Once we have those 2 IV lines, we choose one of them and we administer the medicine into that IV line over 60 minutes. At that point, when the medication is completely infused, we do what's called a flush, which is where we flush some saline, which is not containing medication, through the IV line to make sure that all of the medicine has been infused. At that point in my hospital, we have an observational period. That has become shortened since FDA approval. We started out asking our patients to stay 6 or 8 hours after the infusion was complete, and we have now reduced to about 4 hours after the infusion is complete, mostly because we're not seeing any immediate infusion reactions. That patient then is able to be discharged home. It's important to keep in mind that this is the experience of our administration at my hospital, and so every hospital may approach this in a different manner, have different precautions, and have different timelines. Post-gene transfer care is incredibly important. So we want to try to reduce inflammation, and remember the way that we're doing that is through this prednisolone liquid medicine that the patient is taking once a day. The dosing of this will be adjusted based on laboratory results. so it may need to be increased if the laboratory results are showing us evidence of inflammation, and it may need to be decreased if the laboratory results result reassuring. Blood labs for monitoring for adverse effects are performed for 3 months after the infusion is complete, and so the patient will go once weekly to have labs drawn for 1 month, and then every other week after that for 8 more weeks. So we have a total of 3 months minimum of laboratory monitoring. The physician may decide to pursue laboratory monitoring longer than that, depending on the results that are returning. Home care, as we've mentioned, is incredibly important. And so once the patient has arrived back home, we want to make sure that we're keeping them comfortable and managing any symptoms of adverse effect. Some patients may have absolutely no adverse effect, and some may have some of those that we see listed here. So one of them is vomiting that was mentioned before. Sometimes vomiting can be controlled with a little dissolving tablet called ondansetron. This may help out with some nausea. Upset tummy can happen more as a result of the prednisolone that we're giving. And so once again, we can utilize ranitidine or famotidine in order to address this. Fever, in my experience with my own patients, has occurred most typically somewhere between 24 and 72 hours following infusion. And for this, we can utilize typical medicines for fever like acetaminophen or ibuprofen, keeping in mind that most pediatricians do not typically administer ibuprofen in babies under 6 months old. Because of vector shedding, so remember that we delivered this medication through this vector, this shell of a virus. That shell is going to be released, it's going to come out, and the way that it comes out is in the form of waste in stool and urine. And so we'd like to have people avoid contact with that shell, not because it is infectious or dangerous, but because if you are starting out as an individual having negative antibodies, so you've not been exposed to this particular antigen in the environment, we do not want to have you positive for antibodies or place you at risk for that in the event that one day down the line you may need some sort of viral vector therapy yourself. And so the way that we manage this is with handling wet and dirty diapers in particular with gloves and disposing of them in plastic bags for 1 month following gene transfer. The majority of that shedding occurs right after the infusion, and so 1 month is quite a long time, but that is being conservative. We may see that over time we adjust these timelines or completely do away with these recommendations, but for now, in order to be comprehensive, this has been recommended by the company. We need to discuss vaccination needs. So it's important for the physician guiding the infusion and the treatment of this patient with spinal muscular atrophy to communicate to the pediatrician or the family medicine physician that's taking care of the child. We consider avoidance of live virus vaccines. So I typically recommend to pediatricians to avoid the rotavirus vaccine. That's the only live virus vaccine in babies under 6 months old during a time of prednisolone management. We consider adjusting the vaccine schedule during prednisolone management beyond just avoiding live virus vaccines, sometimes because we want to make sure that we are getting the vaccine response. And so some of our children, if they are taking prednisolone, may have a dampened immune response to that vaccine, and that might mean that the vaccine may not actually be doing its job. And so in some scenarios, we may want to just adjust the schedule. We do not want to avoid vaccines. Vaccines in our high-risk patients, including those with spinal muscular atrophy, must be pursued in order to protect the child, but we may need to adjust the timing of those. Synagis is a vaccine that protects against the RSV, respiratory syncytial virus, and it is not contraindicated. It is actually recommended per standards of care. So we do not recommend that you adjust your RSV shots during this time period. ongoing multidisciplinary care is absolutely critical. So we have to have a team approach when it comes to our patients with spinal muscular atrophy. And I would not be able to take care of the children that I serve and the adults that I serve that have rare neuromuscular disease if it weren't for this comprehensive team. So I've broken them out in groups so that you can see each of them. We have our physician specialists. So I serve as the neuromuscular neurologist, and I'm pleased to work with some fabulous physical medicine and rehabilitation physicians alongside me. We have a pulmonologist because remember, we can't forget about the potential for neuromuscular respiratory insufficiency. So each of these physicians is critical to the care of a patient with SMA. You may see that at a particular site, the neuromuscular neurologist or the physical medicine and rehabilitation physician may serve as the team leader or the director of the clinic. Collaborating physician specialists may be utilized as needed. So remember that we may still need our orthopedic surgeons. We may still see scoliosis. Bone health is incredibly critical to our patients, and so involving an endocrinologist may be needed. Of course, where would I be without my specialty coordinators? We have clinical nurse coordinators and research coordinators as well, so that we can offer patients the ability to participate in some of these new therapeutics that are revolutionizing our practice of medicine. We have our collaborative clinical team members, including our critical neuromuscular physical therapists and occupational therapists. And in some locations, you may see occupational therapists work alongside speech therapists, or you may have either or at your site. A respiratory therapist is part of our team as well. And in an era where we know that nutrition is key, having a dietitian is incredibly helpful to the support of our patients as well. We have a social worker, an educational liaison. Both of these work collaboratively in order to make sure that once our patient leaves the clinic, they're supported, and that is not only in the home, but also at school as well. And then we can't forget our supportive device team members, including our orthotists, our wheelchair specialists as well. Continued care of the SMA patient is absolutely necessary. So despite any form of treatment, whether it be gene therapy or otherwise, the patient continues to have a diagnosis of spinal muscular atrophy. So to clarify, because this can be confusing, even though we have delivered a missing piece of DNA to the body, a repeat DNA test would actually still confirm a missing or mutated SMN1 gene because this medication does not integrate into the patient's own DNA. It simply sits in the fluid within that motor neuron cell. Visits should continue in an SMA center clinic routinely, so every 6 months is standard. And then for our younger children, our infants and toddlers, we may see you more frequently than that, about every 3 months. Consideration of participation in registries may be discussed, so we know that with these novel therapeutics, we have the opportunity to be able to provide information back to our SMA community and our neuromuscular community about what these therapies do. We can do that by collecting data through registries. And then we also want to make sure that we continue to offer opportunities for ongoing research, interventions, or support. Even if a patient has already had one therapy, there may be more that they might be a candidate to receive.
Thank you, Dr. Proud. Next, I would like to introduce Tanicia.
Thank you so much for allowing me to have this opportunity to be able to speak. Today, I will be going over the clinical overall experience of the process of getting started for gene therapy. I will be discussing the prescription start form, talking a little about the navigation of cost, and I will go over some terms, specialty pharmacy versus buy and bill. I will go over the process of getting the drug shipped and scheduling the infusion, and I will also discuss a little bit about the One Gene program. The prescription start form is the first step in the process of beginning therapy. This form serves as a written consent as well as a prescription. The form is not an insurance authorization, and that is very important to know. Most families believe that once the start form is signed, then everything is ready to go, but there is a process afterwards. Next, we will be discussing the navigation of the cost of drug. The first step after submitting the start form will be an insurance authorization. All insurance companies will require a prior authorization, and this is where we reach out to the insurance company and ask them if this therapy is a covered service. The first step would be to either fax or call the insurance plan to request an authorization review. The diagnosis of spinal muscular atrophy does qualify as an urgent request. There is important documentation that you would like to submit, so we will need to have genetic test results as well as AAV9 antibody test results. A letter of medical necessity may be needed, and this is essentially a letter written by the provider going into detail about why your child may qualify for the drug and why it's important that they have it. And also, it is important to have an updated weight documented because we want to make sure that we are authorizing the correct dosage for the child. Typically, the request needs to be reviewed by the insurance company's medical director, and that is mainly because of the cost of the drug. In some cases, it may need to be reviewed by two people. Turnaround time for a standard review can take up to 14 days. Urgent cases can take up to 72 hours. Once we have submitted that, we wait for a determination. If there is an approval, there may be additional steps that are needed. If the facility will be going through a specialty pharmacy, there is going to be a letter of agreement involved. And the letter of agreement is where the pharmacy and the insurance company negotiate the price of the drug and reimbursement. If the facility decides to do buy and bill, the facility will need to have a contract in place with the insurance company. In the event that there is a denial, that is not the end of this process. There are options to do a peer-to-peer review, and this is where the provider will speak with the medical director, or in some cases, it may be a pharmacy director at the insurance company, and fight for the drug, give details on why the drug is important, why it is a medical necessity. Some insurance companies do not allow a peer-to-peer review, and in that case, an appeal may be needed. And also, if the decision cannot be overturned in the peer-to-peer review, then an appeal may also be needed. The families can also submit their own appeal request in writing. Now we will talk about specialty pharmacy versus buy and bill. So as I discussed before, some facilities like to have the medication dispensed by the specialty pharmacy. And in some cases, the letter of agreement is necessary. And the pharmacy and insurance company will negotiate terms of purchasing the medication. This process can take several weeks, and that is very important to know because most people are under the impression that once we have an approval, then that's the final step and we can go ahead and schedule an infusion to get the drug. That is not the case most of the time. This letter of agreement is necessary and able to be able to ship the drug. If the facility is going to do buy and bill, next slide, please. The hospital buys the medication and the insurance plan reimburses the hospital directly. This contract must be in place before the drug can be shipped. This also can take several weeks, so it is important to know that specialty pharmacy versus buy and bill, one is not faster than the other. It's just the facility's choice of which route they're going to go. After a contract or a letter of agreement has been obtained, the drug is ready to be shipped to the facility. This can usually will happen in 24 hours. Please note that weekends and holidays may affect this.
Thank you, Dr. Proud and Tanicia. We sincerely appreciate your time and expertise and everything you do for our neuromuscular community. The information you shared was incredibly valuable and extremely educational. Also, thank you again to our event supporter, AveXis. We wouldn't be able to provide events like this if not for your generous support, so thank you very much. If you have questions around the MDA Engage program and/or items from this webinar, please feel free to email them to mdaengage@mdausa.org, and we will do our best to answer them. Do also remember that MDA has a resource center, and it's a wonderful resource for our MDA families. The MDA Resource Center is available to provide one-on-one support via phone or email for individuals and families looking for information about the disease in MDA's programs and more. This concludes today's MDA Engage Gene Replacement Therapy for SMA webinar. Thank you very much for attending, and we look forward to you joining us for future webinars and in-person educational activities.